Welcome, welcome, welcome. Jeff Dunn is my name from the Prostate Cancer Foundation of Australia. And let me welcome you again to this special session where we launch the fourth edition of Your Guide to Prostate Cancer, the disease, treatment options and outcomes. And joining me is Associate Professor Prem Rashid. Prem is an eminent urologist, well respected and known both here in Australia and abroad. He is a long-serving supporter of the Prostate Cancer Foundation of Australia, and he currently serves as the president of the Urological Society of Australia and New Zealand. And of course, most important of all for our session here today, Prem is the author of this book. Prem, welcome to you.
Thanks, Jeff. It's nice to be here. Thanks for the invite. As you say, long association with the PCFA.
Indeed you have, and we do appreciate it. And Prem, fourth edition. So can you just tell us up front, it's been just on 10 years, it's been over 11 years, I think, since the third edition. What's changed for the fourth edition?
A lot has changed. Look, I said after the third edition that I would never do it again, because it was incredibly hard. What I try and do is try and reach that balance. What I hope is common sense advice, not to suggest that you don't get that, but people do, as doctors, we're quite rushed, as you well know, and sometimes that information that we're trying to convey to you in the time that we have just doesn't get achieved. So what I've always wanted to do is have something aside as if I'm speaking to someone as a urologist, and trying to take them from the A to Z, as if we're sitting down having a cup of tea and they've got time to quiz me about everything. So the process originally started probably 20 years ago when I wrote a book called Your Prostate Questions Answered. And that was about all conditions, the benign conditions and cancer. And I started to write that as a pamphlet for patients. I just thought a few questions that people commonly ask that I could hand out. And then it grew, and I think I ended up with 104 questions. So ended up putting a book together. And that was quite successful. I was surprised. I knew at that point that there was firstly a market, but also this appetite for patient guidebooks where someone with a condition would just want to read it and make notes, and then be able to go back to their specialist or their GP and ask questions about what they were wondering about. So that then became the first edition of Your Guide to Prostate Cancer. And as I brought that book together, I thought it was just one of those things. Every time I did something, I thought I can do a little bit better. The second edition came about not long afterwards because I basically wasn't happy with the first edition. I thought I could do better. I was happy with the second edition. But again, I remember the first day I opened the box and saw the second edition, I knew I was going to do a third edition. I just thought yet again, there was something here that was missing. And I wanted it to ramp it up to a more professional looking book that was pleasing to the eye, easy to read, and well proofread. So what I did was engage my colleagues to look through various sections. When the book was smaller, I could get a colleague to look through the whole book. But as it grew, what I started to do was get people to look at sections. So, we're all busy people and it's hard to read a whole book. And I also asked other people to contribute. For example, the radiation chapter was essentially written by a colleague of mine, Tom Shakespeare. The brachytherapy section was written by Joseph Bucci. And at one point, Rosie King very kindly literally gave me a whole chapter when I contacted her about some of the sexual health issues. And she said, take this. And I said, oh, I was hoping you'd help me write the chapter. She said, just take what you want out of it. Then I read it and I said, can I use all of it? She said, yeah, use all of it. I said, can I edit it? She said, yeah, edit to your heart's content. So that chapter still remains. Thanks to Rosie. When I contacted her this time, she said, just keep using it, got no problem. So some of the sexual health stuff overlaps because I wrote a chapter and then I included her chapter because I think she, as a sexual health physician, covers things in different ways. And then over time, I've had other people review chapters and offer insight. So the book starts with, what is a prostate? What is the PSA blood test? What are the investigations? Why is prostate cancer important? And goes through some of that initial investigation. Some of the new stuff you asked about, I guess, is the better way we use PSA these days. It's still a test of prostate activity rather than prostate cancer activity. So it's got a little bit of a problem with that. but it's still the best blood test we have. As you and your viewers would know, MRI of the prostate has started to become in common use over the last 5 years or so. It's been very helpful to limit the number of biopsies that have occurred, because one of the criticisms of PSA screening, as you well know, is that it led to transrectal biopsy and infection and over-treatment sometimes. So once we had MRI, that was important. The second and the third edition did not have that. Then other things like PSMA PET scanning, which recently the government has agreed they will fund. Hopefully it'll come into the funding model next year. PSMA PET scanning, which people like Declan Murphy and Michael Hoffman have spearheaded that work, and I'm very glad to say that Declan was involved, and some of the images of PSMA PET scanning appear in that chapter. And then treatment, treatment has progressed not just with surgery in the robotics, but also radiotherapy has progressed, as has brachytherapy. And then beyond that, if you get advanced disease, we have hormone suppression and then some of the many newer drugs. And people like Ian Davis in Melbourne have been involved in fine-tuning that chapter, along with Stephen Begbie, both medical oncologists. So I've been really lucky to have people alongside, happy to contribute in areas that I'm not that familiar with. And then unfortunately, finally, at the end, things to do with palliative care. And one of our palliative care physicians, Will Kennett, kindly reviewed that chapter as well. So generally, I write the chapters and then I get them to proof it. And then I send it through to multiple colleagues. I think there's over 100 names in the book. Not all have been involved with this 4th edition, but over half of them have. And they give me their various views, and I've just got to work through and try and work out where's middle ground here. Some people have very strong views one way or the other. I try to find middle ground. And then I get a proofreader to read it to make sure the language is easy to understand. And then we go into a design phase.
Fantastic. So you're able to pull together what amounts to a team effort at times. So you're guiding and directing the ship, but you're calling in favors, expertise, and experience from a broader network, which is terrific. And it certainly shows when you look at the book, and it is an impressive list of names of people who support you in this work and who have given of their time and expertise to make sure this is the best it can be.
Absolutely. You couldn't do this as a one-man show or one-woman show. It just wouldn't work. Yeah. So because, it might be a self-promotion. I hope it doesn't come across like that, because I like this book to represent, the sort of common view that you would get, covering as much as you can, including the controversies and what's behind them. And then having, organizations like the PCFA and my own Urological Society of Australia and New Zealand to look at the text, at arm's length, and see whether each organization was prepared to endorse, and they both kindly agreed, which I think really helps the credibility of the book.
Well, here, and it's important to note that just as you've said, that both the Urological Society and Prostate Cancer Foundation of Australia have endorsed this 4th edition and have endorsed previous editions. Because when you think about resources available out there with regard to prostate cancer, your guide to prostate cancer is a staple, and it has been around since 2003 in various editions. So it's fantastic. Prem, tell us, who do you think, when you're writing the book, who did you have in mind as the target for this book? Is it written for any particular group or individuals? Is it?
Well, as a urologist, I see the guy I'm writing for every day, in their form. So it's the average guy who walks through that door, may or may not have symptoms, has had a PSA usually, and that PSA has been abnormal. They're usually a bit concerned. Some are a bit blasé about it, but most people are a little bit worried about, they know this is a cancer test. They're turning up, they know they're likely going to have a rectal examination, which, people joke about, and, they're sort of got some ambivalence about it. And if the GP hasn't done it, which is common, then most urologists will do that rectal examination, just at least for the first time. And then most men have realized it's not such a big deal. But then begins the complex discussion of the fact that this test may suggest a problem, and lots of if buts and maybes about, what this means. Even MRI can be difficult for some people because it's a fairly long study. Claustrophobia can make it difficult to have the test. As well as if you have hip replacements, it can make the pictures a bit unusable. And some people with cardiac pacemakers, for example, or other metal implants can't have an MRI. So people have to navigate all that. So it's for the average person who's working through that process. And then if it's deemed appropriate, then a biopsy of the prostate and sampling of tissue from the prostate and how that's done. And that's evolved. And then if we do find a prostate cancer, as you would know, low-grade disease, which we call grade group 1, or what used to be called Gleason 3 and 3, can be managed with surveillance. In other words, no treatment. And the man has to, and his family need to understand why you would look for a prostate cancer and then find it and then tell them you're not going to treat it. It seems counterintuitive. But you have to explain that, well, you don't need treatment because that might carry side effects. And we'll get to it eventually, but in the years when we don't treat it, then you don't have to suffer with any side effects. And of course, the other end, when it's quite advanced disease and the difficult conversations around it. So it's for every man who walks through that door who has a prostate problem who needs a bit of advice.
Yeah, and the book comes highly recommended, of course. And, for men, for their family members, of course, as Prem said, and, health professionals as well, who may come into contact with men who are facing the disease, who might not specialize in it or see it routinely. It does have a wide remit. Prem, so, the first edition came out 20 years ago, plus or minus a couple of years. The president of USANS, the peak urological body in the country.
Yes.
Well, in two countries, Australia and New Zealand.
In New Zealand, yes.
And you've been practicing as a urologist for many, many years. I mean, what have you noticed? You spoke before about some of the changes in updates from, edition 3 to edition 4, but
yes,
just upon reflection, what's happening what's different now about prostate cancer, how we manage it and treat it and how we work with patients?
Yeah, the great questions. When I started, now almost 25 years ago, all you had was a PSA and then a transrectal prostate biopsy without local anesthetic, with 6 to 8 biopsies, as many as the friendship would allow, before people would faint or say they'll never have it again. And then what was then a suboptimal sampling of the prostate, but that was all we had. Then not long after that, we introduced local anesthetic into the prostate to numb that, but still the probe going into the anus was uncomfortable. Then came sedation, so that at least you could have this while you're asleep and not have to notice it. But transrectal biopsies still carried this risk of about 2% of men who would get an infection. And a small number of them would end up in hospital with a serious infection needing intravenous antibiotics for a few days. So a colleague of mine, Jeremy Grummett in Melbourne, often talks about this, transrectal infestation or infection of the prostate. And I think he calls it Trexit to get out of this, because if you use transperineal biopsy, which we're becoming, more and more people are doing now, your infection rates are extremely low. The study they did in Melbourne, showed very, very low rates. But it is harder to do while the patient's awake. So the biopsy technique has changed. The ability to sample the parts of the prostate that we were probably undersampling before with the transrectal technique has also improved. Infection rates have dropped. Then depending on what we find, as I said, low grade, low volume disease can be managed expectantly. So that part has changed in terms of diagnosis. As MRI came to be used, it gives us more information about the localized nature of the prostate or its extent in that general vicinity. And then, as I mentioned, PSMA PET scanning in terms of those aspects. If you look at treatment, well, we've generally been good at treating the disease if it's confined to the prostate. In other words, if it's localized and hasn't gone anywhere, removing it or giving it radiation has generally been quite good for treatment. Where we've always struggled is the preservation of erections and sexual function and preservation of urinary function, particularly continence. That's where we just don't get the trifecta. We cure the cancer, but we just don't get the other two. Progressively with time, we've got much better with that. So it is unusual now to have treatment and have someone who has poor continence. In surgery, people will have incontinence for a while, but it generally gets better. And for those in whom it doesn't get better, the vast range of things we can use now, from pelvic floor exercises as the most conservative things, as well as time to let things to recover, to the various slings and implants that now help us bring men back to continence. With sexual function, again, I think it's the one thing that we still need to get better with, because the nerves that run to the prostate, to the penis, run right next to the prostate. And no matter how meticulous you are in your ability to get that prostate out, erectile dysfunction is an issue. And men will not generally, they'll say it's fine, it's cost of doing business, I lost my erections. But we all know that's not true. If you walked in the door with good erections, you'd like to walk out the door with the same. And currently they don't do that. So we have our pills that help us. We have injection therapy that can help us, and then penile implants. Now, while men may philosophically not want to use supplementary treatment, you want it to be there for those who are willing. And you do need them to know that that's available perhaps before they make their decisions. In Australia, and to some extent New Zealand, penile implant surgery is not available in the public system. So if you have private health cover, you can generally have one, but in the public system, you're left without it. And I think that's a great disservice to our men. If you use breast cancer as an example, women will have reconstruction if they wish that, and it's available in both public and private systems. So one of the things I'm looking at is to try and work out how we can get some sort of funding system in place to make sure that men who suffer with erectile dysfunction after treatment can actually get the treatment that was caused by the cancer that was treated in the public system.
I agree. Very important. Very important. Prem, there's been 10 years between edition 3 and edition 4.
Yes.
Can you just fantasize for us for a moment?
Yeah.
Think ahead another 10 years and you have a hankering
Yes.
to write the 5th edition. What could we expect in the 5th edition? I mean, what's your hope for advances over the next 10 years?
As a surgeon, I would hope that operating on the prostate is something we keep doing. That's what me and my colleagues like doing. But if you think about what will be best for the patient, what you really want is to improve targeted therapy, or what we call focal therapy. That's been around for a long time now, whether we freeze the prostate or burn it in some way or just damage the tissue that we know is there. So if we can get our MRI images to the point where we really do pick the cancer and get to the point where we don't even need to biopsy it anymore, then we can find it with MRI and perhaps with PSMA PET scanning. We can characterize it, and then we can target it either from the outside with perhaps a small needle into a spot and just damage that area, like we burn off a skin cancer. Or we can give you some sort of medication as a tablet or through an intravenous medication that hones in on that spot and damages that area, but nothing else. So, in a perfect, Star Trek world, you'd have a little scanner, or big scanner in this case, that finds it, isolates it, and then treatment that can be delivered to one or multiple locations and destroys that, and you walk out the door. Sexual functions preserved, continence preserved, life expectancy is unchanged. That's the Star Trek version.
Well, I like the way you envision the future, Prem. Seriously, and let's hope, because we are making some terrific advances, as you've already indicated, in relation to how we detect this disease, how we manage it, and how we support patients. And who knows what the next 10 years will bring. And we appreciate your leadership in this. Writing a book for anyone is a labor of love. It's a calling. You've got to have some passion for it. It's a big part of someone's life. So Prem, this is the 4th time you've done this with your guide to prostate cancer. I mean, what are your hopes for this 4th edition? I mean, what are your hopes?
As it has always been, to deliver information to the man and his family, so they can sit down somewhere at home, read it, understand it, make some notes, come back and ask good questions, and also ask the questions they didn't know they were going to ask. Project where they will be thinking should a complication occur, like erectile dysfunction or urinary incontinence. Consider what they would do, pardon me, consider what they would do if the disease cannot be cured, what sort of treatment they would avail themselves to, and in the final stages of life, work out how they want to be managed in palliative care. It is a journey. Prostate cancer is a very long journey for some men. I still vividly remember a man who I started treating in his mid-80s, and we both agreed that because he was older that we wouldn't treat him. So his PSA was rising. I think it was before MRI, but I knew what it was. And I think at the age of about 88, I said to him, you know, shall we start treating it? This was with hormone suppression. He said, no, I'm 88. Let's keep going. And then I think it turned up at 92 again. PSA was double. I said, well, it's time to treat it now. And he said, no, I think I'm right. I'm a 92. And then he finally turned up in hospital at 97 with a broken femur, the long bone of the lower leg, the upper leg. And I felt really bad because I thought I could have stopped this. You know, 10 years ago, I could have stopped this. But we had frank discussions. He felt he was getting older. And certainly into his 90s, I wasn't going to argue with him. He knew what he was doing. And I went and saw him, and I felt sad. I really genuinely felt sad. And I apologized. And he said, what are you apologizing for? And I said, well, you know, we could have stopped this. He said, and what would I then die from? I'm 97 years of age. My family have left me. My wife died many years ago. The kids and grandchildren are on their way. None of my friends are alive. It's time to go. And he said, I'm very happy it's finally happened. And he died within a day or two. I always remember that story because it made me realize that the patient has to drive the decision. Our job is to give them that information so that they can drive their own decisions, not for us to make the decisions for them, but give us all the information that's of relevance to them. And I hope this book does that for the majority of people.
Yeah. Well, I can assure you, Prem, and all those watching, that the Prostate Cancer Foundation of Australia is very proud to stand beside the Urological Society of Australia and New Zealand in endorsing this 4th edition of Your Guide to Prostate Cancer. And we congratulate you, Prem, on producing this updated edition of a very important text. And to anyone out there who is interested in learning more about this or in getting a hold of a copy, Prem, how might they do that?
It's available through the website. So www.prostatebook, one word lowercase, prostatebook.com.au. Okay.
And of course, anyone out there, we also have a link on our website at PCFA. So you can go to pcfa.org.au to get the link. Your Guide to Prostate Cancer, as Associate Professor Rashid has told us, is a book for anyone with an interest in learning more about prostate cancer. And we are delighted to be a part of its launch here in this session today. So Prem, on behalf of all of us, thank you for that. Thank you for your time. We do wish you all the very best for the book. And on behalf of all of us, we do thank you for your passion and commitment in producing an updated 4th edition, which we know will be of great benefit. Thank you very much.
Thank you, Jeff, and thank you to the PCFA for doing this for me. I couldn't do it without the support of all the people around me, including family, staff, and of course my colleagues who helped, and those patients who continued to support the book and the work that's done.
Hear, hear. Thanks. Remember, visit the website, get a copy of the book. Thank you, everyone. Thank you, Prem.
Thanks, Jeff. Take care. Bye-bye.
Bye.